As part of our workshop on obstetric emergencies, we are next going to look at the diagnosis and management of severe preeclampsia and eclampsia. And we need to find out why it is important, what is the underlying pathophysiology, so we can manage the disease based on the pathophysiology. What are the common clinical features, and what should we be looking for in terms of diagnosis, and to how to optimize management. So let us start with a case history. We have a 31-year-old primary gravida who with suspected small for gestational age fetus, and she was induced at 38 weeks of gestation. She did not have any other medical or obstetric risk factors. Her blood pressure was entirely normal, and she was considered as a low risk patient until the ultrasound scan at 36 weeks of gestation, which showed that the fetus was small. So as the induction was progressing, her cervix was about 5 centimeters dilated and the CTG was entirely normal. Suddenly she complains of sudden onset of headache, pain in the upper abdomen, as well as flashes of light. So let's now take a step back and think of the diagnosis. My question to you is, what is the diagnosis? So please discuss with your neighbor in the workshop, and the facilitator would help you to come to the right diagnosis. Because as doctors, as nurses, midwives, if you don't get the diagnosis right, our management is not going to be optimal. So based on the history and the symptoms and signs, let's come to a diagnosis. So there is no doubt that this is a manifestation of preeclampsia, because the fetus was small, so that is placental disease, which is often associated with preeclampsia. And this woman who was normally well suddenly gets symptoms and signs which are suggestive of preeclampsia. But based on the symptoms, we need to now decide whether it is mild, moderate, or severe. So again, discuss with your neighbor and the group to see whether this is mild, moderate, or severe preeclampsia. So I'm sure you would have agreed that this is imminent preeclampsia because it has got CNS symptoms. So please remember that 1 in 5 patients can come to you with convulsions or eclampsia without any preceding high blood pressure, hypertension, or proteinuria. And when we look at the disease pathophysiology, we'll understand why that happens. So this is a case of imminent eclampsia, which means she may start convulsions very soon because she is having cerebral symptoms, headaches, flashes of light, and that's because the occipital lobe is supplied by the posterior cerebral artery, which is the thinnest blood vessel in the brain compared to anterior and middle cerebral arteries. And therefore, when there's intense vasospasm and edema, that's the vessel that is going to get affected, causing ischemia to the occipital lobe, which is dealing with vision, and that results in visual disturbances, flashes of light, seeing colors, etc. So let's now go forward with the diagnosis of imminent eclampsia. So then, what are the principles of management? Once we make the diagnosis, please remember it's always ABC. Airway, breathing, circulation. We need to stabilize the mother first, irrespective of what the fetal heart rate is telling you. Because if you have an unwell mother, we may end up losing both. So airway, breathing, circulation, we need to have intense monitoring. Pre-eclampsia is a multi-system, multi-organ disease, and therefore we need to do a gamut of investigations looking at different organ function. Pre-eclampsia can result in disseminated intravascular coagulation, DIC, and therefore we need to check the hematology, clotting factors, etc. So the principles of management, once we stabilize the mother and do the investigations which are necessary, check blood pressure and control blood pressure if there's hypertension. Because this is a case of imminent eclampsia, we need to prevent convulsions, and once we stabilize the mother, we need to plan the optimum timing of birth after maternal stabilization. So delivery is definitely indicated because it's imminent eclampsia. How we deliver and what's the mode of birth and timing of birth will all depend on maternal condition as well as the other factors which are risk factors. It is only after we stabilize the mother, please check the fetal heart rate. Otherwise, we might end up losing both if you concentrate on fetal heart rate first. Unwell mother means it's increased risk to the mother and the fetus. So why is preeclampsia important? This is the confidential inquiries into maternal death in the UK in October 2024. Every 3 years the report is being published, and you can see preeclampsia is one of the direct causes of maternal death. Still, it is a direct cause of maternal death. Despite good antihypertensives, despite free availability of obstetricians, midwives, anesthetists, intensivists in the UK, and many hospitals have maternal medicine specialists, ICUs, magnesium sulphate freely available, midwives and nurses. Even with all that, we are still losing patients with preeclampsia, and often due to delayed treatment. 45% of all our maternal deaths in the UK are due to substandard care. A different care may have given rise to different outcome, very sadly. This is the current report in September 2025. Again, preeclampsia continues to cause maternal death, which is very sad. So let's look at the pathophysiology. The key requirement to have preeclampsia is to have an ischemic placenta. So the placenta can be ischemic if in early pregnancy, about 16 to 18 weeks, if the second wave of trophoblastic invasion does not take place. We know that the trophoblasts have to go and remodel the spiral arterioles by destroying the tunica media and replacing them with fibrin. If that process doesn't take place between 18 to 20 weeks, after 16 to 18 weeks, after 20 weeks, a woman might get preeclampsia. And that is why, by definition, preeclampsia is defined as any increase in the blood pressure after the 20th week of gestation, which is associated with proteins, at least 2 readings of high blood pressure 4 to 6 hours apart, with a minimum reading of 140/90. The definition 20 weeks is there because 16 to 8 weeks is the time the second wave of trophoblastic invasion is completed. In that case, it is very obvious that this woman is going to have early onset preeclampsia after 20, 21, 22, 24, 25 weeks, because the placenta has become ischemic much earlier. Whereas about 7 to 10% of patients may have maternal cardiac dysfunction, so the cardiac output is not sufficient to perfuse the placenta at term because of some maternal cardiovascular problems, and because of that the placenta gets ischemic, and that is the late onset preeclampsia. The next question is, okay, the placenta has become ischemic, but how does it increase the maternal blood pressure? So ischemic placenta is supposed to release a factor called factor X, I think there is increasing consensus that this factor X could be S-FLT or soluble tyrosine kinase. Uh, it could be, and that is the way the research is going at the moment. But it is called factor X because we don't know. But what we know is that it is an endothelial toxin. So it's going to affect endothelial cells, and the endothelial cells are present everywhere in the body in blood vessels, and therefore obviously the manifestations are going to be multi-organ and multi-system wherever there are blood vessels. So irritation of the endothelial cells is going to cause vasospasm. That results in increased peripheral resistance and hypertension. At the same time, if you go and damage the endothelium due to endothelial toxins and the renal endothelium, the glomerular apparatus, renal endothelium gets damaged, it starts leaking proteins, and you get proteinuria and hypoalbuminemia. And then, due to the loss of proteins, reduced colloidal osmotic pressure and hypoalbuminemia, as well as endothelial damage themselves, you started getting edema. And because the endothelial cell is damaged, you get platelet activation, and platelets get consumed. We are going to get thrombocytopenia associated with that. But once the disease progresses, there's diffuse destruction of endothelium, leading to diffuse activation of the clotting system, leading to consumption of the clotting factors, which result in disseminated intravascular coagulation. It's not in one area of a blood vessel, it is everywhere, so it's disseminated intravascular coagulation. And because of vasospasm and formation of these thrombi in very, very tiny blood vessels, the end organ arteries, we are going to have ischemia and multi-organ failure. And in severe cases, you may have hemolysis, because as the red cells go through damaged, very narrow blood vessels, they get hemolyzed, they get damaged, and that results in hemolysis, and the liver gets involved. Then you have elevated liver enzymes, and platelets gets consumed, and that is the HELP syndrome with serious morbidity and mortality. So approximately, as I said, 20% of the cases, the vasospasm may be absent, but the rest of the pathology might take place, and because of that, a woman might come to us with convulsions as the first presentation. So pre-eclampsia is a multi-system, multi-organ disease of unknown etiology. In the absence of knowledge about the exact etiology, there is a disease of theories. The only way we could solve the problem is to remove the placenta. And the earlier the pre-eclampsia occurs, then the cost is iatrogenic prematurity of the fetus. To save the life of the mother, we need to then deliver the placenta, which means delivering the baby with the placenta, causing prematurity. So as I said, soluble FMS like tyrosine kinase receptor 1, S-FLT, is the one that is showing some promise, where we could detect the levels early and predict and manage preeclampsia perhaps in the future better. So it has a diverse clinical picture. You think of every organ or tissue in the body, it gets affected with preeclampsia. But please remember, our clinical assessment in the antenatal clinic is only limited to blood pressure and proteinuria. And 1 in 5 women can have convulsions, eclampsia, and other problems without demonstrating these factors. So in terms of definition, blood pressure more than 160 to 110 is considered to be a severe preeclampsia, or it can have cross nephrotic rate, gross proteinuria, HELP syndrome, severe oliguria, and symptoms of progression as this patient had: headache, visual disturbances, epigastric pain, hyperrefractia, and due to placental disease, you could have severe growth restriction, especially in early onset preeclampsia. In late onset preeclampsia, the baby may have grown normally and therefore we may not get any clinical symptoms and signs of severe growth restriction oligohydramnios. So here we need to realize that approximately 20% of women may present with eclampsia without hypertension because it is endothelial disease. So there are lots of clinical symptoms and signs. Depending on the severity of the disease, you might get these symptoms and signs. And it is important to recognize the complication. Approximately 1 in 10 of women with severe preeclampsia might suffer from HELP syndrome or placental abruption, and eclampsia is about 1 in 200, and the maternal death is, again, case fatality rate is about 1 in 200. So the maternal observation, because it is a multi-system, multi-organ disease, the standard vital signs, plus we need to monitor the myocardium because the myocardium can get affected in severe preeclampsia. We need to monitor the neurological function. Apart from assessing orientation and drowsiness, the deep tendon reflexes and hyperreflexia is a way of assessment. We need to look at urine output, less than 30 mL per hour in general, but please, individualized care is 0.5. Usually the urine output is 1 milliliter per kg per hour. This will be less than 0.5 milliliter per kg per hour. And then, because preeclampsia is a multidistal disease which is going to affect the endothelium of the lungs, it is going to cause pulmonary edema if there's endothelial leakage and hypoalbuminemia. We need to also check the oxygen saturation and respiratory rate. And this is just to show you how right from 1950s the diagnosis of preeclampsia has pretty much remained the same. There's not much of change in terms of what is the degree of proteins. It's about 0.3 grams in 24 hours or 300 milligrams in 24 hours, and the protein creatinine ratio of more than 30. So these have remained pretty much the same, and we need to always look at the risks of continuation of pregnancy and the risk of immediate birth. That's the difficult balance for obstetricians, especially in such a situation, because if you continue pregnancy, there's a risk of fetal compromise. The woman might have eclampsia and multi-organ failure and worsening hypertension. And if we intervene too early in the preterm period, there's a risk of prematurity, cerebral palsy because of prematurity, and iatrogenic prematurity, including neonatal admissions, prolonged stay, etc. So this balance up to about 32 to 34 weeks tilts in favor of continuation, provided mother is stable and fetal Dopplers are normal, etc. And the cardiotocograph doesn't show any evidence of chronic hypoxia. But after 34 weeks, if there's a severe preeclampsia, obviously the balance will tilt towards delivery because the risk of prematurity now is much less. The next question to ask yourself in your own hospitals where you're working: do you have evidence-based clinical practice guidelines on severe preeclampsia, eclampsia, which is crucial, and that the guidelines should tell you about the definitions of what is chronic hypertension, what is eclampsia, what do you mean by hypertension in general in pregnancy, what is the definition, what do you mean by gestational hypertension, that is a new onset of hypertension after 20 weeks of gestation. So it was not present before, it is coming for the first time after 20 weeks but without any proteinuria. Then you have HELP syndrome. Preeclampsia is the new onset of hypertension defined by systolic is more than 140, diastolic more than 90, as we said, after the 28th week of pregnancy, with the presence of one or more risk factors, including proteinuria. And usually it's a good practice to take this blood pressure twice 4 to 6 hours apart if it is mild hypertension. Whereas if it is moderate or severe, it's better to accept the results because it's more likely to be correct. So then the other maternal organ dysfunctions, we need to look at renal function, liver involvement, liver functions, hematological abnormalities, uteroplacental dysfunction, including placental insufficiency leading to growth restriction, stillbirths, etc. And then if it is severe preeclampsia, then we need to control the blood pressure to prevent stroke, renal failure, and heart failure. At the same time, we need to prevent convulsions. So admissions, it's very important to admit the patient in the right environment. So in mild to moderate preeclampsia, she could be managed in a ward, but in a severe eclampsia or imminent eclampsia, she needs to be in the right place. That is an ICU, intensive care unit or obstetric high dependency unit, with all the key doctors, midwives, nurses able to look after. So if we have to give an emergency medication in a severe hypertension situation, labetalol is the drug of choice. But in bronchial asthma, we should not be giving labetalol, because an alpha and beta blocker, it can cause bronchospasm, and the maintenance dose is again IV labetalol at the rate of 20 mL per hour or 40 milligrams per hour. That's the maintenance rule. Patients with cardiac disease and asthma cannot have labetalol. It should be used with caution. If there's an urgent need to reduce the blood pressure, we could use hydralazine, which is a direct arterial dilator, but the problem is it needs preloading because it can suddenly reduce the placental perfusion, precipitating a prolonged deceleration, culminating in fetal bradycardia. Especially these fetuses may not have sufficient reserves because of growth restriction. The placenta may not have sufficient reserves because of prolonged uteroplacental insufficiency, thrombosis, infarction, etc. And therefore we need to be careful. After we administer hydralazine, according to your guideline, please check the blood pressure every 15 minutes, and the maximum bolus is 15 milligrams. So it's 5 milligrams at a time, and therefore with a slow intravenous infusion, and 15 milligrams is a total dose. In 2025 onwards, it has been there for a long time. We use magnesium sulphate. It's a calcium antagonist. It prevents eclampsia in about 40 to 50% of patients. So still, let's not reduce our guard. Just because we give magnesium sulphate, it doesn't mean that it will prevent eclampsia 100%. It can reduce the risk of convulsions, but it doesn't eliminate it. So we need to be very careful. Even if we start using magnesium sulphate, we know that we need to have a loading dose of 4 grams followed by maintenance dose of 1 gram per hour, and the guideline should say what to do if there's a convulsion. If there's a convulsion while giving a magnesium sulphate, we can increase it to 2 grams per hour. And it should be continued for 24 hours after birth or cesarean section, or 24 hours after the last convulsions. So all these should be clearly given to the staff, and sometimes if the toxicity level increases, as long as the urine output is normal and there are no symptoms and signs of toxicity, it is not necessary to do routine magnesium levels. But if the urine output is low, magnesium is an ion which is excreted with difficulty by the kidneys, and therefore it is better to do the magnesium level. But if you have any of these, because it's a calcium antagonist, so it is going to cause vasodilatation, it's going to take away the muscle tone, so loss of tendon reflexes. It will cause weakness. It causes orbital muscle weakness, so you have double vision. It takes the muscles of the oral cavity, so if there's slurring of speech, and then it just as the disease, as the toxicity increases, you have respiratory rate getting lower because of intercostal muscles not being active, and that's the time respiratory rate and the oxygen saturation are important. And if there is toxicity, the antidote is 10 mL of calcium gluconate IV. So please make sure that if the woman is on magnesium sulfate, we are not looking for increase in the respiratory rate. Here we are looking for reduction in the respiratory rate because of calcium antagonism. So emergency treatment, we need to have various codes, emergency code, we need multidisciplinary treatment, involvement if there's a convulsion. It is all about preventing injuries to the patient, preventing aspiration, making sure airway, breathing, circulation is maintained, make sure that there's enough oxygenation, and also then start the process of administering anti-epileptic drug, which is magnesium sulfate. So severe hypertension, always make sure there's airway, breathing, circulation is maintained. Labetalol in mild and moderate hypertension, we can give it orally and then recheck blood pressure. If it is contraindicated because of bronchial asthma or cardiac disease, nifedipine can be used as the alternative to labetalol 10 milligrams orally. And then we have to keep monitoring the blood pressure to make sure that she is improving. And if the blood pressure is fluctuating or if it is severe hypertension, then we need to go for intravenous labetalol or hydralazine if a 5 milligram slow intravenously to make sure that blood pressure is kept within reasonable limit, not to reduce it too low because then that will reduce placental perfusion. A diastolic of 90 to 100 would help us to avoid maternal risks as well as fetal compromise. Systolic blood pressure has to be reduced because confidential inquiries have said if your systolic blood pressure is over 160 millimeters of mercury or the mean arterial blood pressure is more than 125 millimeters of mercury, there's an increased risk of cerebrovascular accidents or stroke. And if the mean arterial blood pressure goes more than 140 millimeters of mercury, that is very, very serious. So we need to really make sure that the blood pressure is kept under control. And if there's a convulsion, call for help, secure the airway. Suctioning of secretions is very important. We don't want aspiration. Turn the woman to the left lateral tilt, check for breathing, and then manage the emergency with convulsions should be controlled with magnesium sulfate, and then control the blood pressure, make sure there's fluid restriction. So the principles of management of preeclampsia is a multidisciplinary approach. We need to have high dependency care with trained staff and the necessary equipment. We should have flow charts, protocols, and guidelines so that there is no variation in practice. And in an emergency, everyone knows what to do. And it is all about maternal stabilization, control of blood pressure, and control of convulsions. Either prophylaxis, or if it happens, then we need to treat. So again, let me emphasize, we need to stabilize the mother first, then we control the blood pressure next to prevent stroke, heart failure and renal failure, and then we need to make sure that we prevent convulsions with magnesium sulfate. And if convulsions does occur, we immediately secure the airway, breathing, circulation, and start the anticonvulsant magnesium sulfate and keep her in an area like intensive care unit or obstetric high dependency unit, which is staffed by competent and experienced staff who can recognize complications and manage complications. Thank you.